Hi, everybody. My name is Andrea Matsumura. I am a sleep medicine physician at the Oregon Clinic, and I am also an internal medicine doctor by training. I am a fellow with the American Academy of Sleep Medicine, and I am also a fellow with the American College of Physicians. So, my talk today is going to be on insomnia. And the title is Help, I Have Insomnia. But a subtitle I thought about is I have a patient with insomnia. What do I do? And there's a whole host of things that can be done for patients with insomnia, but there are very few tried and true treatments that actually work. So, moving on, this is a bit of the overview of my talk today. So, we're just going to go over really what is insomnia? What is it? What is acute insomnia? What is chronic insomnia? What are the treatment options for insomnia, both pharmacological and non-pharmacological treatments? And then a few case presentations and then summary. So, first off, what is insomnia? Insomnia is the inability to either get to sleep or stay asleep. And most of the time, it takes people 30 minutes or less to get to sleep. So, if it's taking somebody longer than 30 minutes to fall asleep consistently, more often than not, that is a form of sleep onset insomnia. Now, if somebody is having trouble staying asleep and they're waking up in the middle of the night to the point where they're looking at a clock or they're wondering, when am I going to get back to sleep? As opposed to potentially a quick wake up and then falling right back to sleep, that's what we call sleep maintenance insomnia. So, some of the symptoms can be, again, delayed sleep onset or waking up very early because you just can't get back to sleep, feeling unrefreshed when you wake up, feeling as though, I'm giving myself 8 hours of sleep, but I'm only getting five, or trouble maintaining sleep, having middle of the night awakenings where it's taking you a while to fall back to sleep and you're wondering when you're going to fall back to sleep. And you sometimes end up doing things. A patient may end up doing things in the middle of the night thinking that they're helping themselves. And then ultimately, what that leads to is daytime impairment. So people don't feel like they're functioning well because they have insomnia, because they're not getting good sleep, refreshing sleep, enough sleep. So then they feel like they're dragging all day long. So the classification of insomnia, there is primary and there is secondary. So primary insomnia is what we would call idiopathic. We cannot find a reason why somebody has insomnia. And there are a lot of reasons, as you can see on this slide. Or they may have sleep state misperceptions. So there is that phenomenon. So that means that somebody is actually getting enough sleep, but they don't feel like they're getting enough sleep. That's different than hypersomnia. So patients who have sleep state misperception, they typically don't feel sleepy during the day. They they feel unrefreshed, like something's missing. However, they're getting plenty of sleep, but they're not truly impaired during the day. Now, secondary causes of insomnia, several, several out there. Most of them are comorbid conditions. So, drug abuse is a big one because clearly that affects your ability to have a normal circadian rhythm, a routine. Mental disorders, bipolar, any kind of thought disorder, mood disorders certainly can affect the ability to feel refreshed. It can cause problems with getting to sleep and staying asleep. Anxiety is a big one. Medical conditions, so heart failure, any type of lung condition, kidney condition can cause insomnia because sometimes people have like itching from their kidney failure, or they just don't feel like they're getting refreshing sleep. So virtually almost every major organ in our body can affect our sleep cycle in some way. Pain is a big one. Pain, I see quite often in the office, and there hasn't been an association made that, hey, you're having insomnia because you're waking up from pain. Stimulants, we clearly see a lot of stimulant use right now, and stimulants inevitably will cause wakefulness and can contribute to insomnia. So people will kind of end up taking their stimulants whenever they kind of feel like they need it. And many times that's too late in the day. So making sure that if you do have a patient on stimulant therapy, it's really clear when they should be taking it. And then depressants. So the most common one, alcohol. Alcohol affects people's ability to get into REM sleep. So if you're someone who drinks a lot, you have a patient who drinks a lot rather, uh, that inevitably is going to affect people's ability to get into the right stages of sleep. It may in fact allow somebody to fall asleep easily, but they don't get into the right stages of sleep. And REM sleep is the most important sleep because that is uh, the stage of sleep where we are cleaning out the waste products of the brain. And so that is really important. And people will feel terrible when they wake up and have to go back to sleep sometimes or take a nap to get some of that recovery REM sleep. Other things that can affect sleep are biological factors or other biological factors, such as heightened cortisol levels, reduced estrogen and progesterone. That's getting a lot of press right now because of all the data that's come out around hormone therapy and the recognition that women are truly having problems in sleep around perimenopause and in the menopausal state. Okay, so moving on, what is acute insomnia? So acute insomnia, and this is the International Classification of Sleep Disorders, third edition. That's what ICSD-3 stands for. And just a book that basically has all sleep disorder classifications. So the ICSD-3 classification of acute insomnia is when a patient is suffering from either initiating and or maintaining sleep, but it's fewer than 3 times a week and it's for less than a month. It typically is happening to someone when there's a traumatic event. So the one that always comes to mind as an example that bubbles up frequently is the death of a person or the ending of a relationship. So those clearly can make people have acute insomnia. It is an unsettling event, and it can definitely change somebody's threshold for sleep. Something that might be a good thing, but definitely can affect people's sleep is getting married or moving across the country. So now that might be a good thing because people generally are moving because they're going to a job or some new adventure, but it can be anxiety provoking or it can just cause some unsettling. But really the most important thing to remember about acute insomnia is that it is just that. It's acute, it's short-lived, and it's happening for less than a month. Okay, so then what is chronic insomnia? So chronic insomnia is when somebody is having trouble initiating sleep and or maintaining sleep more than 3 times a week for more than 3 months. And that is when it becomes a chronic situation. And oftentimes it is a comorbid condition, meaning there is something else that is causing this insomnia. So I often say there's an underlying driver for it. So there is this concept that by a psychologist named Spielman called the 3 Ps of chronic insomnia. And that's predisposing, precipitating, and perpetuating. It didn't put it in this because it's really not relevant or germane to what you're going to be doing every single day with the patient. This is really for somebody who's seeing a sleep psychologist or a sleep specialist. But in summary, the predisposing is, we all have 1 or 2 nights of insomnia a year, let's say, or every 6 months. We don't know what causes it, but the very next night, we're good to go. That's predisposing. Precipitating is when there is an event or this comorbid condition, rather, that happens, and that resets somebody's threshold for sleep. Now, that most people can go back to their predisposing and they would fall into the acute insomnia. But some people move forward and it's called perpetuating insomnia, or in other words, chronic insomnia, because now it's hardwired in the brain and it's this new pathway that the brain has developed, a new a pathway of hypervigilance and disruption in sleep. So, causes of insomnia, again, mental health, such as depression, anxiety, thought disorders, mood disorders, sleep anxiety. So, if somebody has had a difficult time uh, getting to sleep, then you develop this anxiety around getting to sleep. So, then you have this sleep anxiety. Other sleep disorders, such as sleep apnea, restless leg syndrome, hypersomnia disorders. Uh, this website for the ASM has a whole bunch of education for patients and clinicians just around all of the different types and causes of insomnia, and that's why I put it in here. It's a good reference. So, diagnosing insomnia. So, how do we do that? Well, a lot of people come to me and say, I'm here because I can't sleep, and my doctor thought I should get a sleep study. Sleep studies are not actually indicated for insomnia. It is a clinical diagnosis. So oftentimes it's simply me having the luxury of time as a consultant, having time to really dig deep into a person's routine and figure out what's happening, what's causing the insomnia for the most part. Sleep logs help. So I often think that in a primary care setting, sleep logs can buy you some time and help you kind of figure out if the patient is in fact getting enough sleep, because most of us are chronically sleep deprived. Most people don't get enough sleep, and most people are not aware that that's the problem, that they simply just need to be better about getting themselves into bed at the right time and giving themselves enough sleep for the time that they have to wake up. I often find that wearables can be helpful for me in diagnosing insomnia, although I always say that with a grain of salt, because patients tend to hang on to all of the numbers as though they're diagnostic. So, what I often will tell patients is that they're great for trends, but they're not diagnostic tools. They're not capturing data every second. They're giving you little summaries every few minutes. And the way that each wearable identifies sleep is different. And so, and all of those algorithms are proprietary, so we don't really know how they're capturing the data. And then diagnosing insomnia is often overlooked. It's just, you know, something that most people don't even think about. They'll just say, well, I have trouble sleeping and that's just my life. Or at the end of an appointment, they'll say, oh, hey, you know what? I've been having a lot of trouble sleeping. And then they get a prescription for a sleep aid written for them, which really is just kind of like a little band-aid over a big problem because it's probably been long standing. So this is how I diagnose insomnia. I go through a whole bunch of questions. I will have people sometimes fill out a sleep log, and sometimes I will engage with people's wearable device information because it helps me understand where that person is coming from. All right, so then the treatment of insomnia. So I'd like to go over this before I get into medications, because it is often not cured, but it's managed. So once somebody, and this is to clarify, this is chronic insomnia. So I did not put that in the title, but this is truly the treatment for chronic insomnia. because remember, acute insomnia is short-lived, and that is usually resolved within a month's time. Chronic insomnia is chronic. It's ongoing. The person is not getting any better. So it's often cured, not managed. And that is because once that pathway is laid down in the brain, we want to quiet it, right? But then there's always this opportunity for that pathway to get woken up again, let's say. So what the ultimate way to treat chronic insomnia is with cognitive behavioral therapy for insomnia. So we all know that umbrella term, cognitive behavioral therapy, but there are many different forms. There is a particular form for insomnia, and that is ideally the person being treated for their chronic insomnia with CBTI with a sleep psychologist. So sleep psychologists typically have taken an extra course around CBTI specifically. The good news here is that there's a 70 to 80% success rate of patients achieving this therapeutic response of increasing their total sleep time. The one caution is that a lot of psychologists or a lot of therapists out there will say that they help people with insomnia. Unfortunately, what they focus on only is sleep hygiene. And what we really want to focus on in the setting of chronic insomnia is the hypervigilance, hyperarousal state that has become this learned behavior. So it's not really just preparing yourself for sleep, but it's also understanding and learning what is causing that hypervigilance. That's often why it is a comorbid condition. So the three main components of CBTI is improving the sleep hygiene, a concept called stimulus control, and then another concept called sleep restriction. Now, I put in here on this slide, sleep aids, not recommended, because sleep aids really, their purpose and their indications are for the acute insomnia. That's what sleep aids are for. So I see so many people with chronic insomnia that are on all kinds of sleep aids and they don't work, but they're using them because they have developed this ritual around the need or the notion, the idea that they need this medication in order to help them fall asleep, when in fact it's not doing anything. So bottom line here, the treatment of chronic insomnia is with cognitive behavioral therapy for insomnia. It is not sleep aids. Okay. So that first piece around sleep hygiene, let's talk about that, because this is the part where I think a lot of people who are practicing, who are in primary care could probably, there's a handout, a sheet. This is like the first step for anyone. So regulating the sleep time and wake time, I put that at the top because that is the most common reason why people have bad sleep hygiene. It's because they are going to bed at all hours. Like, I'll ask patients and sometimes they'll say, well, sometimes I go to bed at 9, other times I go to bed at 11. Sometimes I go to bed at 7 when I'm really tired. Other times I'll go to bed at 1 a.m. because I was watching a movie, and it's all over the place. And then their wake time generally is the same, but then they'll sleep in when they have a day off, and it's just irregular. And that completely contributes to insomnia. Exercise. So we want people to exercise. There is data out there that shows that exercising helps people with their circadian rhythm. It allows people to fall asleep easier, having more restful sleep. Now, there was at one time where we thought that exercising right before bed was not a good idea. It could be too stimulating, but there are people who love to exercise at bedtime because it relaxes them. So, that data hasn't really proven to be, as impactful as we once thought. And what I often will ask people is, well, you kind of know yourself. So if you exercising right at bedtime relaxes you and helps you fall asleep, then that's good. Do it. But if it doesn't and it makes you wide awake, then that's bad. Don't do it. So you kind of have to figure out whether or not exercise is something that it could be a positive or a negative around sleep hygiene. Reducing alcohol intake. So as I said earlier, a lot of people don't realize that alcohol, well, maybe most people in middle age or older realize this, but a lot of folks will not realize that the alcohol is affecting their sleep stages, and that is in fact then causing problems with sleep. So you want to be mindful around how much you drink and the timing. So there's a 6-hour half-life. So if you drink too much too late, it's definitely waking you up in the middle of the night. So sometimes people will time it and say, well, I can't drink after 6 p.m. because I want to be asleep at 10 and have a good night's rest. Avoid napping. So, a lot of people will think, oh, I didn't get good sleep, so I'm going to nap during the day and make up for it. And then they just repeat the cycle. So when we wake up for the day, generally speaking, there is this homeostasis in the body, and there's this sleep pressure that is low generally, and then it increases throughout the day. Now, if we take a nap, then we reduce that sleep pressure. So then when it's time to go to bed, it's not high enough to actually promote sleep. So excuse me, so then people are repeating that cycle because they are continuing to nap every day because they're not getting the sleep they need at night, because they're not building up enough sleep pressure to help them fall asleep at night. Avoid caffeine in the evening. Again, we know that caffeine has stimulating and alerting effects in the brain. And when people say, oh, I can drink caffeine and it doesn't affect me, there is a very small subset of people that that is true for. But what that really means to me, for the most part, is that you're confirming that you're chronically sleep deprived. You have so much built up adenosine in the brain that the caffeine, which competes for those receptors for sleep, the sleepiness, which is adenosine promotes sleepiness, and caffeine, when it binds to that same receptor, clearly promotes wakefulness. You just have so much sleep pressure built up, so much chronic sleep deprivation that any amount of caffeine is not going to really help. So again, no caffeine in the evening. Smoking cessation, clearly it's stimulating the brain, and we know that it causes insomnia. And then the last one that I highlighted is do not use electronics in bed. We are all guilty of that, I'm sure. That just promotes sleep, and the all of that business around, oh, I'm using a particular type of light that is not going to be stimulating. Well, we have ganglion cells in the eye that directly connect to the wake center, and it doesn't really matter what type of light. If we've got light right here because we're looking at a phone, a tablet, or a computer screen, or a television, anything like that is going to give our brain mixed signals. So that's that really electronics. I always tell people 1 hour before bed, stop all electronics. And then I hope that they will stop, 30 minutes before they go to bed. So that's sleep hygiene. That's one of the key components. Now, the second component around CBTI is stimulus control. So stimulus control just means making sure that there isn't anything that is causing wakefulness or promoting wakefulness while you're trying to get to sleep. So the big one here is associating sleep with the bedroom or a bed. So if you do things in your bed, then you're kind of telling your brain that it could be the kitchen table or the sofa. So when you only want to be in bed when you're absolutely ready to fall asleep. You don't want to hang out in bed. You don't want to be eating, watching TV, reading for too long. So a little word about reading, that's a slippery slope. So if you know that reading a book really makes you really sleepy and within 15, 20 minutes, you got to turn the lights out, then that's a good thing. However, if you're an avid reader and you're engaged in this book, and then you look up at the clock and say, oh my goodness, it has been over an hour that I've been reading because I can't put this book down, then that's not the time to read. So again, we want to associate sleep with the bed and the bedroom. So do not lie in bed. So again, we don't want to spend time because again, the brain is pretty simple in this regard where it's thinking, well, I can do anything in this bed. You want to use eye covers if you can, if that's something that's positive, earplugs. If so, sometimes people live in a noisy area or have noisy neighbors, and using earplugs helps. Eye covers help, especially in the Northwest part of the country where I'm at, where I live. It's light out for a long time. And if you don't have blackout shades or you're very sensitive to light, rolling over at, 5:30 in the morning when you don't have to wake up, that could be problematic. The other piece is relaxation techniques. So developing like imagery or breathing techniques, the like tensing and relaxation, those are good techniques to use to help somebody get themselves back to sleep. So how do we use stimulus control when we're talking about helping somebody with cognitive behavioral therapy for insomnia? So typically, this is that piece where we say, if you wake up in the middle of the night and you cannot fall back to sleep, you want to get out of bed and you want to do something very relaxing. That's where the relaxation techniques, the breathing techniques, the imagery comes into play. You do not want to wake up, get out of bed and go cook, clean, work, exercise. These are things that people will do because they can't fall back to sleep. I always tell people, pick a chair or, part of the sofa where you know that you're going to go to every time you can't fall back to sleep in bed, and then do something really relaxing to help yourself get back to sleep. And that is what is stimulus control. That's the nuts and bolts of it. But these other pieces also help kind of set that stage for getting back to sleep, using the eye covers, the earplugs, not lying in bed. Those are the key components. So then the other piece is sleep restriction. This is the hardest part because it is the fastest way to help people improve sleep efficiency, but it is the hardest. So what is sleep restriction? So somebody comes to you and they say, I can't sleep. I'm only getting 5 hours of sleep, but they're spending like 9 hours in bed. Well, what sleep restriction is you, if they told you that they're only getting 5 hours of sleep, then typically we tell patients, okay, then you get 5 hours in bed. And so what that does is it improves sleep efficiency. But again, in the sleep world, everything is sleepy, nothing happens fast. So we're training the brain. So sleep perception, this is hard on the psyche, but it's highly effective. That I wrote all this down because the thought of somebody only spending 5 hours in bed is hard for sometimes patients to accept. So again, this is more for, seeing a sleep psychologist or a specialist, but just so that you know that there's these three major components, which is, sleep hygiene, stimulus control, sleep restriction. What a sleep psychologist ends up doing is there's a little formula that helps a person kind of fade into, gradually and fade into increasing sleep efficiency. And you do it in 15-minute increments. So, let's say somebody says they're only getting 5 hours of sleep. Well, then we might say, okay, we'll only spend 7 hours in bed. And then we try to increase that sleep efficiency in 15-minute increments by having people do some calculations around actual time in bed versus time asleep. So that's left for, the sleep psychologist or cognitive behavioral therapy intervention specifically. But just so you know, these are the three components Again, highly successful way to help people retrain their brain to get to sleep and or stay asleep and improve overall sleep time and sleep efficiency. And I always tell patients that chronic insomnia is a diagnosis of exclusion. That's why they're here to see me. I need to make sure there's nothing else affecting their sleep before we move forward with the diagnosis of chronic insomnia. And then we want to identify the underlying drivers of that. And the success of getting to increase your sleep, I always say to people, it's not a couch to 5K, it's a couch to marathon. This is a 3 to 6 month adventure that you're doing to help improve your total sleep time. Now, that might sound daunting. However, most people that come to see me who have chronic insomnia, it's been going on for years. So then I try to put it in perspective and say, listen, whatever you're doing right now, it isn't working. And you just told me that you haven't had good sleep for 20 years. So doing this hard work for 6 months to set yourself up and the rest of the years of life for to set that up positively, it's a small window of time really compared to what's happened in the past and what you can have to look forward to in the future. So there is that piece that it sounds hard at first, but really it's a great intervention to help people get back to the sleep that they may have had once in the past. Or some people will say, I never had good sleep, and that then we have to figure that piece out too. But the other big component is dealing with the comorbid condition. And that's the hard piece. And there's so many things that can affect sleep, right? So other medical conditions, mental health, uh, medications, hormones, environment, pain, all of these things can affect people's sleep. And undoubtedly, what I often will see is that a person has an underlying anxiety and it's not really been treated or discussed because they haven't really brought it up because they're typically, functioning folks during the day and they're compartmentalizing, and then when they're left only with their thoughts and themselves at night, that's when the anxiety rears its head. And a lot of people initially will say, well, I don't really have anxiety. And then I have to explain to them, well, if it's affecting your sleep and it's impairing your sleep and you're struggling during the day, then it is worthwhile to treat your anxiety. So medications for insomnia, and again, I just want to say these are stats for Americans, um, but 50 to 70 million people suffer from sleep disorders or sleep deprivation at some point. 30% of the population in the world has insomnia at some point or another. Americans spend more than $41 billion on sleep aids and remedies. $41 billion. 60 million Americans take sleep medications every year. Those are astronomical numbers. And that's because there's so much advertising in our country and everybody's sleep deprived, right? Nobody is getting, I feel like nobody, it's an overgeneralization, but I feel like many people are not getting enough sleep and everybody's reaching for a medication to help themselves when in fact, a lot of it is around discipline and around um, this like bedtime procrastination. If you've not heard of that, bedtime procrastination is when we're just so busy throughout the day, we end up using our tablets or phones in bed and scrolling and and giving ourselves this time as a balancing of all of the time during the day that we didn't have to ourselves. But it's really backfiring on people because they're just basically not getting enough sleep. Okay, so having said that, medications, I wanted to throw in here the cognitive behavioral therapy for insomnia resources. So I always recommend this self-help book. It's called Overcoming Insomnia, a Cognitive Behavioral Therapy Approach. And I put a picture of it on this slide because, you can get it on Amazon, and it is a workbook, and it's really tiny. It's about this big, and it's got all of the concepts that I just talked about around chronic insomnia treatment, so CBTI. And if people commit to it, and what I always say is, this isn't a book where you read it and take the pieces you want from it. This is a book where it's a workbook and it's methodical. You need to go over every component and implement every component of the book. That's the success. Not, well, I don't want to do that piece, but I'm going to do this piece. The success rate goes way down. But basically, if you can't find a sleep psychologist in your area, this book is really helpful for folks. Then there's a couple of websites that I've attached here that have CBTI resources on their websites. And there's this free CBT app on iOS and Android that I also put a little piece in here, a little link to. So let's talk about pharmacological treatments for insomnia. Remember, this is mostly for acute insomnia, but we all know lots of folks who have chronic insomnia are on medications. And what I want to focus on, because this is kind of a busy slide to me, is all the little check marks. So all of these medications are FDA approved for insomnia. That doesn't mean that you should be treating insomnia with these medications, chronic insomnia. Maybe short-term acute insomnia, sure. But chronic insomnia, I do not recommend. I don't find that they work well. And there are a lot of different classes of medications. So the 5 big drug classes are benzodiazepines, benzodiazepine receptor agonists or sedative hypnotics, the dual orexin receptor antagonist or DORAs, melatonin receptor agonists, and antidepressants. And then there's another kind of basket that I like to put everything else in that other basket, like antihistamines, herbals, barbiturates, quetiapine. These are other common medications that are used. I didn't put on there gabapentin or Lyrica, but yes, those are also in there, the alpha-2 ligand, those are also in that basket because they're off-label. They're not really supposed to be used for insomnia. But these particular ones here are FDA approved. And so benzodiazepines, we all know how they work. And I'm not going to go into the mechanism of action of all of these because we really don't want to use them for insomnia. But, the big highlights for benzodiazepines are the fact that they're habit forming. And what I find is that people will often need escalating doses to help get the same effect. So there's always this honeymoon period that I say exists for chronic insomniacs, where they'll start on a medication and it works for maybe 1 or 2 weeks, and then it stops working. And then they have to take more medication. So the benzodiazepine receptor agonists, sedative hypnotics, they function similarly to benzodiazepines. They don't have as much potential that for habit forming medications. But the big danger with these is that they can cause parasomnias. So one example, I had a patient that was using Ambien intermittently. And she finally told me that she had accidentally thrown away her Apple Watch. And that's because she had taken the medication and then she woke up and she says, "Oh, I only take my watch off when I take a shower." Well, she wakes up typically each morning and the first thing she does is take a shower. And she put it in the trash with papers instead of where she typically puts it, she said. And she didn't realize it. She couldn't find her Apple Watch anywhere. But then she said, I kind of had this memory like it was a dream of me putting it in the trash. And that's what happened. I have another patient long time ago who was on Ambien and came to me in an appointment and had this gorgeous big giant ring. And I complimented her on the ring. And she said, "Oh, that's my Ambien ring." She had bought it on the shopping network in the middle of the night, didn't know it because she was awake. And then it came to the door, it was delivered to her door and she didn't even know that she had ordered this ring. And then the last example, and another reason why I don't recommend any of these medications, the Zolpidem, the Zaloplan, and the Isopiclone. I had a gentleman tell me that he would wash clothes and prep all dinner, like using knives, prepping dinner in the middle of the night. So he thought it was great because he was getting so much done and still sleeping. So again, these are medications not to be messed with long term. And the reason why they're called sedative hypnotics is because people actually forget when they're amnestics as well. So they're sedative hypnotics, and they have some amnestic potential. So we see this a lot when we're doing overnight studies, and people will be awake for 45 minutes in the middle of the night. They don't even remember it, but they were awake. Their encephalogram shows that they were awake, but they don't remember it. So these medications don't really improve sleep time. I believe that the data, the last time I looked at it, they improve total sleep time by 20 to 40 minutes total. So just a word of caution that Ambien, Sonata, and Lunesta are not to be used long term, and they can cause some serious side effects, including, not only parasomnias, but memory loss. The dual orexin receptor agonists, that's really hitting, receptor antagonist. That's hitting the orexin receptor. So orexin is for wakefulness. The agonists, orexin agonists, cause wakefulness. The antagonists clearly would cause sleepiness. So the medications that I wrote down there, I personally have never prescribed them. So I don't have a lot of experience with these medications because I just don't go there. And I feel like they don't really have a place, but there's marketing and there's a drive and desire for people to get sleep, and people are reaching for these medications. Now, the other last two classes, melatonin receptor agonist, so Ramelteon or Rosarum, that medication is supposed to be a specific, have a high affinity for specific melatonin receptors, and it's supposed to help induce sleep. The studies that were done head to head with regular melatonin didn't show any big difference. So it's an expensive supplement, basically. And then the last class, antidepressants. We all know trazodone. Many of us are familiar with mirtazapine, and we all know TCAs. Those medications have been shown to cause sleepiness. And in fact, if I'm going to use any medication in addition to cognitive behavioral therapy for insomnia, it's typically some form of antidepressant or anti-anxiety medication that is also an antidepressant. That's what I might use, because you're kind of killing two birds with one stone. But education is so key. So when I talk to folks about the fact that I'm actually treating the underlying disorder for this medication, by using this medication, and as a bonus, they might in fact have some sleepiness, it seems to work a whole lot better than if I focused the action of these medications on the fact that it's going to make them sleepy. Then it doesn't work as well. So who knows? That's just my anecdotal, response to how I couch these medications, how I talk to patients about the use of these medications. We all know trazodone doesn't really have a lot of efficacy around being an antidepressant at the doses that we use for sleep, but I still say that this could help. And folks tend to respond pretty well to it. Certainly mirtazapine or Remeron, there's there's pretty good data that shows that it might help with some anxiety. And when I again focus on the underlying driver and then say, hey, as a side benefit, it can make people sleepy, I tend to get a pretty good response. And then the last one, TCAs, you know, I tend to use that when people have tried mirtazapine or have tried trazodone, and I use a low dose. And also, if somebody has some chronic pain, if they're not already on this medication or haven't been tried on it, I'll mention this medication. Now, the other medications, antihistamines, herbals, barbiturates, quetiapine, just off limits. I don't ever recommend those medications. And in fact, if people are on any of these medications, I tell, unless they're using quetiapine specifically for their mental health, I have those people get off of these medications and work with their PCP to help get them off of these medications. Um, all right, so I do want to talk a little bit about melatonin. And the reason why I'm going to focus on melatonin as a sleep aid is because it's so widely distributed and used. I feel like everybody is trying melatonin, and it's really not a sleep aid for the body. So it's a hormone. And how it works is that when the sun goes down, theoretically, there's this whole process called dim light melatonin onset. So when the sun goes down, it stimulates the pineal gland to release melatonin. But that is hours before you actually go to sleep. So it's a clock starter. It's not a sleep aid. And it is sold in really high doses because there was a couple of studies that showed that if we flood people's receptors with melatonin, it might make them sleepy. I'd say 9 times out of 10, patients will say it doesn't work. For that one person that says, oh, I use it and it works great, I pretty much leave it alone. I don't even try to change it, because by and large, if it's working for them or they think it's working for them, it's usually, okay. But for most people, it's not working, and then they just take escalating doses, and then that has side effects. So how melatonin works in the body is that it's released 4 hours before your circadian rhythm for sleep is before you're hitting that bedtime. So let's say if you're in the normal circadian rhythm, um, uh, where you go to bed at 10 and wake up at 6 a.m., you're releasing melatonin around 6 p.m. And then it rises up into the bloodstream. And when it's maxing out, that's kind of when your head's hitting the pillow. And then it typically stays elevated for most of the night. And then when it starts to wash out, that's as morning is approaching and you're getting up. So many people take the over-the-counter melatonin supplements to help them fall asleep. They're considered, natural, but the FDA doesn't regulate any of that. So that's why it can be pretty dangerous. So here's just an illustration of how melatonin works into the up in the body, how it is released in the pineal gland, and then it peaks, and then it stays elevated, and then it's washed out. So that's just a graphic representation of how it works in the body. So the indications to use it, how do I use it? I use it for patients who have delayed sleep phase. And so delayed sleep phase is basically being a night owl. So that person would rather go to bed at 12, wake up at 8, go to bed at 1, wake up at 9, but they have to wake up at 6 or 7 to go to work. So I use it to advance or pull their clock. And I use a really small dose, 0.5 to 1 milligrams. And I typically only use one brand, and that's called Pure Encapsulations. And that is because I don't know what we're getting most of the time over the counter. There was a study that showed that up to 76% of melatonin sold over the counter is not even just, it's not melatonin, or it's not just melatonin. There's other ingredients in it. And then I also use it for jet lag purposes. So to reduce jet lag getting to your destination or coming back home, it actually works pretty well. And there's a really cool app. I get no kickbacks from this app, the owners of the app, but it's called Time Shifter. It works pretty well. It works really well to help excuse me, adjust the cycle of sleep so that it reduces the amount of jet lag that one has. So those are really the only two ways that I use melatonin. So these are the side effects of melatonin, and they're pretty, there's a pretty wide range of side effects. So taking too much, so 3, 5, 10, 20 milligrams of melatonin can throw your sleep cycle off. So when you're taking it at bedtime, you're thinking it's going to help you fall asleep, and it actually just pushes your bedtime later. You have to be careful with the timing. So if you take it too early, you might get sleepy too early. If you take it too late, then you are pushing that bedtime later. The dosing is complicated. So the higher doses can cause headaches, dizziness, nausea, daytime sleepiness, the hangover effect. It can also cause nightmares. Um, and since melatonin again is not considered a drug, it's not monitored by the FDA, there's no real regulatory body that's helping to verify what's in the bottle is truly, what's on the label. So again, it's just a word of caution. It's widely used, and I really don't think it should be the go-to medication for folks. Um, okay, so when to use sleep aids, when to use some of those prescription sleep aids, travel. So that's the most common reason why people outside of an acute insomnia episode are using sleep aids. And at that point, I think, that's okay. If you're having to use it because, you're doing a trans continental, flight, and you can't sleep once you get there, you know, that's okay to use, although I end up promoting that time shifter app more often than not versus sleep aids. But again, if they're short-lived and they're going to be used for just a couple of days, then I think that's okay. In an episode of acute insomnia, using it for 1 to 2 weeks, I think that's okay. Or resetting the circadian rhythm. So when people are really struggling with insomnia and they feel like they're going to die because they can't get any sleep, I usually tell patients, I'll give you 1 week's medication only, but you have to enroll in some form of cognitive behavioral therapy for insomnia, and we need to treat the underlying drivers. And, it works 50-50. I'll be honest. A lot of patients who are at that stage of chronic insomnia where they're just so chronically sleep deprived and they're feeling desperate, maybe 50% of the time it works as a sleep aid. And again, I only give about a week's worth. Okay, so I thought it'd be fun if we went through a couple of cases to kind of put all this together. So case one, and these are real patients that I've seen, and I thought it might be a little bit helpful just to kind of go over what I do when people come to me with the referral or the diagnosis of, I have insomnia. So this is a 53-year-old person with symptoms of snoring, apnea, restless leg syndrome, and insomnia. The patient's been taking trazodone for sleep, 150 milligrams, and they've worked up to that, but they take it 3 hours before bedtime to get themselves ready for bed. And then sometimes they take another 50 milligrams if they can't get back to sleep in the middle of the night. Their bedtime is 10 p.m. They usually fall asleep pretty easily, but then they wake up in the middle of the night around 3 most nights, and then they can't get to sleep. And sometimes they'll get up and they'll do other things, like they play on their computer. Sometimes they have some tea that they end up making, and then they take another 50 milligrams of that trazodone to help them get back to sleep. And then they end up sleeping for like 1 more hour, and then they wake up really tired and groggy. Well, that's typically because they're taking this trazodone. So the key points here is they're not getting enough sleep. They likely have some other underlying disorder that's causing the insomnia, and they're taking too much trazodone. So if you're going to add any type of medication, you want to check in right away. So this person has been taking trazodone for years. I usually limit refills again if I'm going to use any type of sleep aid, which is very rare, they don't get any refills because I want to see them back. Or I tell them this is how long this medication is recommended for. A clear direction on how to use it. Of course, we all know patients are going to take their medication however they want to take it, but I always say do not take it any other way except the way that it's being prescribed for you. And then treating the underlying disorder or disorders. Here, this patient ended up having sleep apnea. They were started on CPAP. They were evaluated and had a workup for restless leg syndrome. And they, in fact, did have restless leg syndrome. And we started them on iron supplements. I started cognitive behavioral therapy for insomnia. I reduced the trazodone to 100 milligrams. I said no middle of the night dosing. And then they eventually were able to stop trazodone after they had completed their CBTI. So this was a success story. But a lot of it was setting the stage for the expectations. Okay, so case 2, this is a 34-year-old person with unrefreshing sleep, goes to bed at 10 p.m., but doesn't fall asleep until 1 typically. They wake up at 6 for work. They take a 1-hour nap every time they get home from work because they said they can't keep their eyes open. And then they repeat the same cycle every night. They're on 10 milligrams of melatonin at bedtime, and they're on 60 milligrams of Adderall, high dose, for ADHD and fatigue. But on their days off, they try to keep the same schedule, but they end up sleeping until like 9 or 10. They don't have any symptoms of sleep apnea, but they came to me saying, I have insomnia. Okay. So this is a classic scenario of somebody who has delayed sleep phase. So here are the key points: circadian mismatch. They're going to bed at 10, but they never fall asleep until 1. And then on the weekends, they're sleeping in. That is the classic presentation of somebody who is a night owl. But of course, many of us work and live in earlier societies. And I always say, if we were living in Spain, France, Italy, this might work. But for people who live in early societies, doesn't work. The high dose melatonin can be dangerous because of what I had just described in the earlier slides around, the irritability, the dizziness, bad dreams, all that kind of stuff. And then ADHD was not officially diagnosed. And the patient says, I'm really using it more for fatigue, but it's not really working. And I see this a lot. I see this a lot where patients are self-medicating at night, but then they've been diagnosed some sort of stimulant, and that stimulant actually could be contributing to the inability to get to sleep, not only the circadian mismatch. So I diagnosed the patient with delayed sleep phase. I used circadian realignment using bright light and melatonin strategically, and I'm basically advancing their sleep schedule. I told them to stop napping, and over time, this person worked with their PCP, and they were able to reduce the Adderall dose to 20, much safer dose. And in fact, they did have some ADHD, but the issue is that they were treating other things besides the ADHD with that medication. So again, classic presentation. And I think this happens a lot because 20% of the world is a delayed sleeper. So 1 in 5 people. So I think this happens a whole lot more often than we think it does, that people are either pushing their bedtime too late because behaviorally they're doing too many things, or they truly have a circadian mismatch and they need some help adjusting it. All right, the last case, case 3, this is a 45-year-old person with insomnia, fibromyalgia, low back pain. They're on quetiapine 50 milligrams at bedtime, trazodone 100. They take both at 11. They sometimes get to sleep by 12:30, but they wake up repeatedly every 2 hours. They feel like it takes them at least 30 minutes to get back to sleep. They have to move around a lot all night, and they wake up at around 8:30, very tired, achy all over. So the key points here, this has been this layering effect of sleep aids that are not working, off-label sleep aids that are not working. and the patient isn't really treating their pain. And maybe they were given the whole spiel around how to treat that pain with non-pharmacologic therapies or pharmacologic therapies. And they always say, well, it didn't work. And then I say, well, what, tell me exactly what tell me more. How did it not work? And almost always, again, because I have this time as a consultant, I pretty much work through the whole process around, well, this is the evidence, this is what we have, this is what needs to happen. And, using these other medications are not going to be helpful, but you have to figure out ways to reduce the discomfort and pain that's affecting your sleep. So the patient was started on a drug treatment option for fibromyalgia. They started a movement program. They stopped the quetiapine and they reduced the trazodone to 50 milligrams at bedtime. So this isn't a case where the person still used the trazodone. But, as we all know, when I think about all of those medications for sleep, that's pretty low on the risk profile in terms of using something long term. So this person, I see this type of patient very frequently. A patient who has pain, either their shoulder hurts or their knee is hurting or their neck hurts, and they're waking up all of the time due to pain, and they haven't addressed it. They haven't really said anything to their primary care physician. And then they come and see me, and I say, well, this is the reason why you're having insomnia. Now, that's the underlying driver. I still end up treating the insomnia, but I also say we have to treat that underlying driver. All right. Well, hopefully this was helpful. In summary, when we're talking about chronic insomnia, we want to treat the underlying disorder, the comorbid condition that's causing that chronic insomnia. Sleep aids generally do not work. Sleep aids are not recommended for more than 1 month at most. Sleep training takes time, dedication, and follow through. Nothing happens overnight. And lastly, if a patient says that they're having trouble sleeping, ask how many hours of sleep they're getting. Ask if they snore. Those are like the two biggie questions. Have them fill out a sleep diary to try and buy some time and gain some insight before prescribing anything if you end up going that route. But again, as I said, I try really hard not to prescribe any medications. Refer to a sleep specialist if needed. And the last thing is, insomnia is not fatal. People do not die from insomnia. They just feel like they want to die sometimes from it. But basically, it is not a fatal disease, and it is completely treatable. All right. Thank you, everybody. And hopefully you'll have a good rest of the conference. All right. Bye.